Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center here in Towson, Maryland. Today's medical tutorial is on Klatskin tumors, or tumors of the common bile duct and common hepatic duct. The common hepatic duct, common bile duct, leaves the liver. This is the liver. And just a little quick anatomy lesson. This is called the common bile duct. Common hepatic duct is at this higher level, close to what we call the bifurcation of the right duct and the left duct. And the purpose of the common bile duct is basically the liver synthesizes and creates bile, which goes into this channel. Is essentially a passageway. The gallbladder is in this area here. And the bile is delivered into the intestine, and the bile helps digest fats, emulsify fats. But what we're going to talk about today is actually tumors or malignancies of the common bile duct. And in this situation, the common bile duct is divided into thirds. And tumors are seen in this area, or in this area, obviously. And the reason we divide them is basically because the operation for removing them may be a little bit different. Klatskin tumors classically refer to common or cholangio or common bile duct cancers at this hepatic bifurcation right here. So this is really the area that we're going to be focusing on later. But this is where Klatskin tumors are located. These distal bile duct tumors are less frequent than the Klatskin tumors, and removing them usually requires what we call a pancreatic duodenectomy or Whipple procedure, which we're going to talk about in some future videos. What I'd like to concentrate today on are these Klatskin tumors. But first, a little bit about what some risk factors are for them. Patients with a disease called sclerosing cholangitis, which is an autoimmune chronic inflammatory process involving the common bile duct, are clearly at risk for these type of tumors. Not in our country, but in other countries, there's chronic parasitic infections which can involve the biliary system. Clonorchis is one of them. We don't see that a lot in the United States, but certainly we do see it occasionally with people who come in from other countries. Probably the biggest risk factor is gallstones or common duct stones, chronic inflammation from this. And then a prior exposure to the medication Thoratrast, or the contrast agent Thoratrast, has also been implicated. But by and large, the majority of these tumors are caused from chronic inflammation from biliary disease. The name of these tumors, they are an adenocarcinoma, and we typically call them a cholangiocarcinoma. And these tumors are difficult tumors to treat because patients present with a blockage in this area and then develop jaundice, sometimes late in the course of the disease. So we're going to draw this biliary system again. I'm going to probably not draw the liver this time. So these tumors are in this location. They tend to crawl up either the right or the left duct. This is the left duct. This is the right duct, and there's a classification system that actually describes tumors that either go up one side or the other side, or sometimes they go up both sides. And these are important to surgeons in identifying which of these patients are operable or treatable. So clearly the goal would be to remove this portion and then put it back together. The problem that surgeons who specialize in this type of problem deal with is that these tumors directly invade the liver in a lot of many situations, as well as some of the arterial structures below. And there's a structure called the portal vein, which delivers blood to the liver, as well as the hepatic artery, but there's a left and a right system as well. And a lot of times there's invasion of the portal vein. So it's not as easy as or as simple as just removing that part of the bile duct. Sometimes it is, but other times it's not. So how do we deal with these tumors? Well, the first thing is to determine operability. So let's take the situation where the tumor crawls up the right system. And there's no involvement, let's say, of the portal vein. So in this situation, this tumor can be cleared by what we call a right hepatic lobectomy, with excision of the bile duct. Sorry, remove this. And then essentially what you're left with is the left lobe of the liver, with the left duct. So that's the liver, and that's the left duct. And then what we do is we bring up a piece of intestine and suture it to the left duct to reconstruct the system. And this is a Roux-en-Y hepatic jejunostomy to the left duct. In addition, lymph nodes that are in this area, or what we call perihepatic or portal lymph nodes, are removed with the specimen. And the goal is to achieve what we call an R0 operation, or no microscopic disease left either in the biliary system at this margin here or at the liver bed. So the situation is similar for tumors that may crawl up the left system. In these situations, the goal would be to remove the left portion of the liver and the bile duct, and then reconstruction would be to the right duct in this fashion. Once again, the goal being to get what we call negative margins, or no cancer at either the liver edge or the bile duct. This scenario tends to be less common because of the fact that the left duct actually has a longer extrahepatic course. In other words, there's actually more length to work with. So the majority of the resections tend actually to be right-sided resections and not left-sided resections. So what about situations where there is involvement of the portal system? Actually, so let's just say that the portal vein, this is the portal vein, and we'll say that the part going to the left here is involved. So the left portal vein is involved with tumor. And here is our friend the liver again. So in these situations, we can actually remove a portion of the portal vein along with the right liver. And what we do is the left portal vein comes out with the right liver, but then this is actually sutured. The venous system, the left portal vein, is actually sutured back by advancing the portal vein, the main portal vein, to the left portal vein. So this is a hepatic resection, liver resection, common hepatic resection, and resection of the left portal vein and reconstruction. Clearly these are complex situations. In many institutions, there are also this particular operation may be performed by a liver transplant surgeon, or surgeons with experience with transplantation. Now, the majority of these tumors are not operable. Probably only 20% or so are operable. So there are situations where radiation and chemotherapy can be given to try to shrink these tumors, and surgery can be performed at a later date. Some patients may qualify for neoadjuvant trials for liver transplantation. We don't perform transplantation at our institution, but there are a few institutions in the United States that give chemotherapy, radiation therapy, and then patients may be eligible for transplant. So these are the options for the Klatskin tumor. I thank you for listening.